Good afternoon, everybody. My name is Jeremy Dixon. I'm the Deputy Director of Exchange. So I'm really pleased to host this seminar by Dr. David Orr, who's from the University of Sussex. So the title for today's presentation is Jumping Hurdles and Appearing Above the Parapet, Navigating Interagency Working to Support People Experiencing Self-Neglect. So David's an associate professor in social work and social care at the University of Sussex. Since 2010, when he first started researching self-neglect and safeguarding, he's undertaken several research studies in this area and has co-written influential knowledge reviews on self-neglect for the Social Care Institute of Excellence. He's led a study for the UK Collaborative for Development Research to develop initial principles to guide safeguarding in international development research, and was co-editor of the Palgrave Handbook of Socio-Cultural Perspectives on Global Mental Health. So before coming into academia, David worked in a community mental health team with older adults. So in terms of the process for today, please put questions in the Q&A box. And if you've got any general comments, then please just stick those in the chat. If you can make your best efforts to make any questions into a question for the speaker rather than a general comment, that's really helpful. It just helps David when he's answering it. In terms of conduct today, we usually just say the common sense things really. Please be polite and respectful to one another, and the university encourages to make clear its policy on freedom of speech, which we've posted, and also just to note that this is a series on adult safeguarding, so there will be some discussion on issues of abuse and neglect, of course. So without any further ado, I'm going to hand over to David, and welcome, David, and thanks very much for joining us today.
Thanks very much, Jeremy, and thank you for the invitation. Jumping hurdles and appearing above the parapet, what have they got to do with collaborative working to support people experiencing self-neglect? What I want to talk about today: why did we study collaboration and self-neglect in the first place? What did we do to study it? The themes we identified, of which there are 4 key themes, and finally, what seems to help, what seems to address the problems that came up in this area. So why this topic in the first place? Why research collaborative working in self-neglect? And I think some of that is captured by this quote. It came from a social worker we interviewed, who said, again, I think what kind of self-neglect, I would say, is obviously the remit of adult social care. With hoarding issues, especially from my experience, it's kind of no one's exact remit. But when we drill down into the policies and procedures, we don't necessarily find that self-neglect itself, aside from hoarding, is necessarily clear everywhere either, whose remit it is. Is it safeguarding? Is it not? As part of this project, I read through the self-neglect policies and procedures of all the safeguarding adults boards in England. It's a fun life being a researcher, and for some it is safeguarding, for others it isn't, and for some it depends. So there are these grey areas and these uncertainties which vary from region to region. Possibly Wales is ahead of England on this. I know self-neglect has been, in safe hands in 2001. It's been very much on the agenda, while England was later to the party than Wales. But there's this uncertainty at times when it comes to the different agencies working together and singing from the same hymn sheet. And then what that actually means for individuals experiencing self-neglect and for practitioners is something like this. As one of the nurses we interviewed said, it's a terribly frightening situation because you want to do the best by people, you're respecting their wishes and their rights as human beings, and then they're telling you that they don't want any help. But it's very clear that everything that's being presented at you, non-verbal communication, the presentation of the house, everything is telling you that this person needs and probably wants help, but is unable to access it for whatever reason that might be. And these are the dilemmas and the difficulties that I think come up repeatedly in practice. How to coordinate, how to develop a common harmonious approach, and how to progress that when there's this ambivalence or this outright rejection of help or support that might, we like to think as professionals, prevent quite serious harm. And we have now well over 500 safeguarding adults reviews featuring self-neglect that tell us that this isn't just a problem popping up here and there. It is systematic. It is recurring. So what we did about it, our study involved a synthesis of policies and procedures. So the 80-odd self-neglect policies and procedures that I gathered from Safeguarding Adults Board websites across England. We synthesized in a review Safeguarding Adults reviews and the research literature. We interviewed stakeholders at 5 different sites around England, including practitioners and people with lived experience of self-neglect. We held focus groups with practitioners to look at co-producing resources, which have gone into workshops that we've done. And then we did follow-up interviews to assess those. What that looks like, 69 interviews with practitioners, professionals in the end, from the various professions that you can see on the right, ranging from social work, mental health, housing, environmental health, fire and rescue, primary care, acute care. And we also interviewed 16 people with lived experience of self-neglect and 2 carers who had relationships with them. And those people, among them, you would find people who have been identified as hoarding, people who with significant alcohol use, accompanying health problems, and deterioration of home conditions as a result, people with skin tissue difficulties, quite the broad range that does come under that umbrella term of self-neglect. What they all had in common is at some point that ambivalence or that uncertainty about self-care or accepting care from others. And the model that we've come up with is a 4-part model of headings of what's needed for effective collaborative working. All 4 of these fold into each other. They don't stand alone, but pathways, protocols, and interfaces, the systems, processes that allow collaborative working to happen effectively. The second, the mutual understanding of each other and of the task. That's mutual understanding by services and practitioners of what each other's roles are and how our counterparts approach the issue. Third is a shared vision of the person and the situation of self-neglect in the round. It's that perception that lets people sing from the same hymn sheet, if you like, and approach the challenges consistently. And fourth is the management, monitoring, and commissioning side, again, that facilitates those things to happen. And I'll talk a bit about what we found for each of those in turn. For the first one, all sites we worked at had self-neglect and hoarding policies in place. Wasn't the case for every single place in England when I looked at the Safeguarding Adults Board websites. Having said that, not all practitioners were familiar with them. And what we see a bit is what Maria Brent calls kind of the policy noise. So practitioners saying they need guidance, but when the guidance is there, it's not necessarily well known or followed. And that's interesting. When we reviewed the SARS, 9 times out of 10, there's a recommendation for new policies or revisions of the policies, even though it's been found that the policies aren't necessarily being followed in the first place. And I think the key thing that came out on that in the interviews was about their usability and the practical application. So do those procedures make clear how the policy can actually be followed? So an example of that might be with questions about mental capacity and particularly executive capacity. Well over half the policies don't mention it. So this would be about people's ability to implement their decisions, put them into action. They can reason them through in the abstract, but they may not then apply them to real life situations. A number of the policies and procedures say it's important to evaluate it, but only a handful actually gave any clue as to how you do that and what that might look like in practice. So I think that was one of the key things, and that's just one example of it, is do these policies, they give a platform everyone's supposed to have signed up to, but do they make clear how that can be implemented? So most of the interviewees we talked to felt those policies and procedures were important. They highlighted a value of being able to say, your agency signed up to this, but there's still the negotiations required over how that works out in practice, what that looks like, funding, or the challenges of getting the intervention accepted. But it was an important base or starting point. But those policies are just kind of framework. They're the bare bones. They tell you what's meant to happen. In some cases, it almost felt like they set up expectations that there wasn't the understanding or kind of shared perspective to put into action. So here we come to the second point, and it's the mutual understanding that services have of each other and what the task is. Now, among all our interviewees from whatever service, people spoke with quite a multidimensional understanding of risk, of harm, of self-determination, of autonomy, of respect for people's decisions. But the emphasis did fall somewhat differently at times, depending on their perspectives. So as one social worker put it, they were talking specifically about environmental health, but I think this could apply to all kinds of interfaces and joint working. So I was quite amazed really about the different ways of working. It was really clear that we just come from different angles here. And what we saw, if there isn't the spade work put in to build that mutual understanding, it causes a lot of problems. It's an interesting quote. So this is where part of the title comes from. One housing manager said, The referrals process is there, a lot of hurdles in itself, but we try to jump those hurdles. And I don't know how much this may resonate for many of you, but it was just a very interesting image how often interagency working was seen almost as an obstacle course that you had to jump over. You had to get around the obstacles. A lot of that was around differing perceptions of risk. Some of it was around, I suppose, I'll come on to talk to shortly about an understanding of self-neglect and the person. But you started seeing kind of blame, accusations starting to appear as organizations talked about each other. For example, as one social worker said, well, the housing association had very middle class values and don't understand why someone would hoard. In the end, I had to say, the judge isn't going to like you doing that. And it shaded into this almost a kind of coercion between agencies. I reserve judgment on whether it's middle class values exactly, but yeah, it's that perception and not understanding what's going on behind the hoarding. The flip side of that, though, comes from housing, where as workers talk to us sometimes, say, to try to raise the issue of the risks and the harms in multidisciplinary meetings can feel like putting your head above the parapet, inviting people to take shots at you, because the emphasis was so much on self-determination and going at the person's pace. So these are some of the conflicts that happen. What maybe sharpens those, makes them worse, was this idea. I think there's an assumption from partners that we have powers that we don't. Now, if I could see you all, I'd be inviting a quick show of hands or a quick vote here as to which organization you think that quote comes from, hence the empty brackets. Quite a lot of you would probably think mine, whichever organization you'd be from. And if that was your answer, you would be right, because almost everyone said that in one way or another. There was a perception among most agencies that others thought they had more power to do things about it, to take action, even either where the person didn't necessarily want that to happen or wasn't agreeing, or that they had powers to somehow convince them to act against the decision they'd been declaring. And I think if we go back to the policies, there's almost maybe a way that that's set up. An expectation is set up where those policies give brief pen pictures in many cases of what the different professions can do. But because they're brief, they don't necessarily point out the limitations on what powers people have. This gave rise to quite a bit of resentment and at times even suspicion. And I quote here from another study by Elaine Aspinwall Roberts et al. They don't want them to have capacity. And that is a quote talking from one agency about another, saying they don't want them to have capacity because then they're going to have to put the work in and the resource in. So they very happily declare them not to have capacity to relieve the burden on themselves. I think those are relatively extreme cases where you get that level of tension between agencies, but at a lower level, it definitely happens. So to some extent, this is something that we worry about within our agencies, makes our professional relationships difficult, but it has real consequences for the people experiencing self-neglect. And this brings us on to the effect this has on agencies that really, to be effective in self-neglect, with all the ambivalence the person might have about agency involvement, really need to have that shared vision of what's going on for the person and what's happening in the situation. What we saw with these issues, as one primary care nurse summed up, said, "You've raised a safeguarding because you're worried for someone's safety in a really acute sense. But then the whole conversation sort of ends up being led by that tone of one professional saying to another, 'I'm giving you this problem, please fix it.'" And I think there's two things that really stand out from that. One is this idea that the situation gets passed from one group of practitioners to another with this expectation that the other group will fix it rather than kind of working together to find a way to move forward. The other is what they say about the tone. "I'm giving you this problem," not "I'm asking you to help this person, but I'm giving you this problem." And it was something we saw coming in. There's almost at times the arms race of trying to build up the sense of risk, highlighting the hazards, the harms, in order to get over what practitioners see as the hurdle to having the referral accepted. It's that arms race, it's that increase in emphasis on the risk, because they feel if they don't do that, self-neglect referrals don't go anywhere. Number one, that reinforces that sense of the person as a problem. It undermines any sense of their strengths or the positive aspects you could start work from alongside them. And number two, just like any arms race, the other side responds. So you see receiving agencies starting to almost discount some of the level of risk assessment there. So, well, they always say the level of risk is high. And yeah, it just has an overall effect on how effectively those referrals and the raising of those concerns works. I mean, it's the kind of the human touch that makes the difference so often, and being able to build on what the group being able to build on what some professionals have been able to do. So, for example, for someone who had no hot water, the partnership coordinator says they were taking a flask with them at a time of hot water to fill up a hot water bottle. The little things that build up that trust and that level of acceptance. That issue of labeling and the problem, the person as problem, this was quite a thought-provoking example of it. Again, from housing, it said there was a lot of rubbish on the communal lawn area in front of the flats, and this tenant was predominantly blamed for it because there was evidence of what was considered self-neglect in their home. So housing were thinking the tenant was responsible. This was raised as a concern. Once they got engagement, they found the stuff outside the property was being dumped by the neighbours of the flat above, who were relying on that person getting the blame. And it was this thing, once that label of self-neglect is applied, people are kind of in the firing line, or anything in their behaviour becomes yet another indicator of self-neglect. And it's important to have that engagement that can look beyond the person as solely a problem. Examples of that, again, it's that human touch, that warmth. Again, this was a housing environmental health officer who kind of proactively kind of knocked on doors where properties were deteriorating. This was the person whose door had been knocked on. She said, "I've come about your ivy and I was mortified." I says, "Oh, you'd better come in if you can get in, with the state of the property." but her kindness overwhelmed me like a warm blanket. It was the initial kindness, the vibes that came from her. And what was potentially very intrusive and very alarming, somebody from housing, from environmental health, asking questions about the state of your property became the starting point for an engagement with support services and a hoarding peer support group. These are kind of the openings that collaborative working can build on where it works well. But the flip side of that, someone else with lived experience of self-neglect told this story. She said to me, and here she's talking about the consultant, "My dear, you pretending won't keep you in hospital." She was accused of faking health symptoms in order to remain in hospital and continue the admission. The symptoms turned out to be genuine. This person had lasting health consequences because it wasn't treated in time. And as I say, since then, I got so scared to ask for help because she said to me, "By you pretending." More than one of the people we interviewed talked about not being believed, of being accused of having arguments about their health, and how that had built this distrust of services. And the effect that that then has on overall trust for the different agencies. That shared vision really needs to take account not just of the person's situation, but of their needs. And one of our interviewees who was autistic talked a lot about how aspects of their neurodivergence had contributed to them reaching a situation of self-neglect. When you look at how that was responded to in the environment, he said, "Every time I feel like things are being expected of me, my brain shuts down and I can't make myself do it. If I can get away from any kind of obligation, I will. I'll seek the shortest path to not having to do it." And they talked about how when practitioners worked well with them, it was about understanding that, managing the demands and the choices that were being asked of them at any one time. So not overwhelming them with choice, which, we try to work towards choice. It's what we do. Saying making that bite-sized. Someone else said it's extremely stressful for me when people are over. I don't like having people in my space and I don't like having to interact with people. But at the same time, you're in a situation where you're asking for help. And you can see how that might make it challenging to accept support or assessment from services, and how it might worsen situations of self-neglect. So it's not just a question of individual practitioners recognizing those things that were raised by our interviewees with lived experience, but the whole of teams or different agencies with involvement kind of having some sense of that and working harmoniously. I suppose just kind of summing up what our interviewees with lived experience communicated to us is this riddle. When is self-neglect not self-neglect? And I would say it's when it's the person self-caring as best they know how. Very often self-neglect responds to those situations where people had found themselves accused or disbelieved by practitioners. It was the distrust, it was the stress that had built up from that. One story was about a man who was living in kind of a converted house, a flat, the condition of the property was deteriorating. There were hoarded items everywhere. What was really worrying the housing team was the entrance. So, door with a sheer flight of stairs coming straight up from the entrance. So as he got older, it was becoming increasingly unsafe, they felt. And they looked to try to move this man to what was seen as a safer property. And he never said no, but equally, he never engaged fully. And it was only when practitioners really kind of got to know him better and understood his background, they learned that he'd been abused as a young man. And for him, these stairs were not a danger. They weren't a risk in the way that professionals saw them. Those stairs, the hoarded items, were a safety measure. They were a barrier. They were something that made it harder for people to get in. I think it's a good example of, what from a professional perspective looked like self-neglect was the person self-caring and trying to protect themselves as best they knew how. And we need to ask ourselves how often this applies to self-neglect across the board and how it makes a difference to how we approach it, to think of it this way. And then finally, back to the kind of systems issues. For this mutual understanding between services to work and to be developed and to be implemented in practice, for this rounded perspective on the person and what the self-neglect means to them, it needs management support. It needs monitoring processes to be managed and the commissioning of services that have the joined up outlook to do that. So managers with commitment, it's this one. There was a very clear drive from the manager. It's not happening again in my service. I'm not prepared to fail people. And it's driven changes. It's somehow addressing the tendency where self-neglect can slip down the agenda. So one social worker ended up kind of being encouraged to almost specialize in self-neglect and hoarding cases, because as they said, other cases were always crisis situations and needed urgent attention. So self-neglect and hoarding always went sadly to the kind of lower priority because the people themselves weren't asking for the help. So it was a manager who supported that happening and was able to facilitate practitioners in keeping it on the agenda. And then the monitoring bit is about how those joined up services are, how the case is made for them. And this was a repeated struggle, I think, in services that we talked to. This quote here, we're using the self-reported outcomes, the dialogue plus, so that gives the sort of personal story and we can use that, but it doesn't feel like that's enough to satisfy budget holders. That self-neglect, because it takes the time and the input, because it's not straightforward or necessarily easily closed quickly, there was always that challenge of making the case for that kind of time-intensive work. So it needed management support for that. So summing up, what are these challenges? I think, what do that lot over there and the other organizations think they're doing? We see these uncertainties over each other's roles, especially what legal powers, say fire and rescue, housing, mental health, adult social care might have. That's not always well understood by other agencies. That yes, there are legal powers. Yes, they tend to be listed in the policies and procedures, but they have limits on them. We see patterns of over and under referral. People almost giving up on referral because they assume it's not going to be accepted. The hurdles are too high to jump. Or over referral, where sometimes it reached a point where not a lot of thought went into the referrals because people assumed they'd be rejected anyway. But, oh, there might be something of self-neglect here. Quick, raise a concern, because we need to make sure that we've done that and that we're covered. There's a distrust that other services will be trauma aware in their approach, and that really undermined involving full teams. This idea that other services might actually lead the person to take not just one step forward with engagement, but two steps back because of how they were received. And where these multi-professional perspectives clash rather than having a common view, you get drift. No progress is made. We saw practitioners feeling isolated with risk as a result, that there was no sense of shared or supported decision making. And examples of wrangling over whose responsibility it was rather than a no wrong door approach. Mental capacity not handled well jointly or understood jointly between professionals. And an issue that learning about it sometimes increased anxiety rather than managing it. And I think it is something about how heavily the evidence base in this field relies on safeguarding adults reviews, which by definition tend to be the cases where things went most wrong. So it kind of contributes to high levels of practitioner anxiety around these issues. There wasn't always a shared language around interagency learning. For example, social workers complained about referrals in not being put in Care Act terms, but those terms sometimes meant something different to other practitioners in other agencies. Information wasn't shared in timely fashion, and there are problems working across the borders, particularly where some organizations span a much bigger geographical area than others, and the policies and procedures can be so different across safeguarding adults boards. So those are the problems. What can we do about them? I think if there's something that's come out of this, it's the need not just for more professional curiosity when it comes to safeguarding and self-neglect, but more interprofessional curiosity. Really conscious, direct efforts to understand why our respective agencies respond in the way they do. So those policies and procedures that can provide shared reference points, and above all, that can link to practical implementation, whether that's executive capacity, whether that's about practical examples of what different levels of risk look like that might occasion a multidisciplinary meeting. Finding ways to bring practitioners together. In some places that was integrated teams. So say a specialist team under safer homes auspices that looked at hoarding, deteriorating home conditions, and brought together different professionals to take that holistic approach. Sometimes it was a practitioner who bridged those gaps. We saw that with homelessness work sometimes. Somebody whose role it was to mediate those rough edges and difficulties. And the value of communities of practice that gave different professionals and practitioners a forum to come together and share those self-neglect concerns, perhaps on a no-names basis, and just to build those skills. Learning from each other kind of in bilateral ways between two individual agencies. Joint visits were really effective in building trust and mutual understanding, or tea and toast drop-ins to talk about what one's own agency can do, what powers they do and don't have, and what works for them. Guidance materials that are truly interagency. So actually kind of explain the terminology or the jargon of social workers for other organizations. And all of that finding ways to de-escalate the referral hurdles, knowing the right route, understanding what the perceived barriers to having a referral accepted are, and building people's confidence in referring. What really undermines that is the rate and the volume of referrals makes it very difficult to feed back. And people find that they're left to speculate often about why referrals are not accepted. But even some kind of collective summary, what are the issues that are affecting these referrals, and feeding back at a collective agency level can be really valuable. In terms of direct casework, promoting trauma awareness as a golden thread. So understanding right across agencies of how trauma can feed in to what we see as self-neglecting behavior, like those examples I said, and recognizing how services, practitioners, agencies may have contributed to that in the past. More inclusive language. So finding ways that recognize the person's strengths, not just, as I say, fixing the problem. Building in devil's advocacy as a feature of those meetings so that nobody is feeling they're putting their head above the parapet to be shot down by saying, I'm really, really concerned about the risks here, even though I support the person's right to self-determination. That devil's advocacy is putting forward a contrary view, possibly just for the sake of it, so that it makes sure it's being considered. That needs to be promoted in multidisciplinary meetings, not seen as a glitch or a problem. People with lived experience on our research team commented that safeguarding seemed to be an area where there was less voice for people with direct experience than in other areas. And maybe that's something we need to work on as a community, as Safeguarding Adults boards. And finally, the positive learning from cases that have gone well, not just from the Safeguarding Adults reviews. As I said, running through all of this like a golden thread is the trauma-aware practice. That's what helps us understand self-neglect and why it happens. These 6 elements. And I think just why we need to think about this. We've seen across this presentation how difficult practitioners and agencies find it to navigate collaborative working. So imagine how complicated it is for someone already experiencing self-neglect, already in difficult circumstances. And I'd like to finish with this quote from Taylor et al. I didn't know there was this whole team of people involved in fixing my life until I later became part of a multidisciplinary team as a professional. It made me wonder if maybe the team existed more to support each other than to support me. I would hope the teams can do both, but it does mean that we need to get better at making the system work for each other and for the people experiencing self-neglect, if that's to happen. So thank you. References and further reading at the end. And I will shut up for a moment now and see what people's questions and comments are.
Thank you very much, David. That was great. So this is a question from MC Hunter. I'm interested in exploring how to get the balance right between respect of a person's autonomy and self-determination and ensuring that they are safe and in good health, and therefore better able to live a meaningful and fulfilling life as possible. I appreciate that everybody's ideas and thoughts are governed by their life experience, but if their perception is keeping them trapped, although safe in their view, how do we support them to see beyond their safe space in case there's a risk of collapse?
Yeah, in a cave that's, yeah, so I take it that's maybe hoarding situation or a situation where the home environment is posing a significant risk. I agree absolutely, and I think that risk assessment is very important. The self-neglect literature emphasizes going at the person's pace as the way to make lasting change. I think sound and careful risk assessment determines how well and effectively you can do that. Sometimes there are immediate risks that might need to be looked at. But I think kind of some of the key considerations in that might be, first of all, an emphasis on harm reduction. So what are the biggest risks and what agreement might be gained to work on those, rather than trying to go all in on everything at once. So that's one issue for addressing risk. How do we support someone to see beyond their safe space? For lasting change to happen, I think it may need to be through that process of building trust. A lot of the ideas behind this rely on a kind of motivational interviewing approach, which is it's the principle of what would the person like to be different, and trying to start from that point. So it might be that their life experiences have meant that, almost being barricaded or protected leads to a sense of safety. What other ways might that need be met? Or for other people, hoarding materials, someone I can think of who, literally lived in tunnels of material. It was all raw material he'd accumulated. He was going to work with DIY, did not want it to be wasted. There was something there about feeling valued. One of the things that was done was to connect him up to a kind of community group around DIY so that he could apply those skills, so that he could use them, so that he felt what he'd done had a purpose. His words were, when you take away 20 tons of stuff from a flat, it leaves a big gap. So it was a question of what you could do to fill that gap. And, as again with the example of somebody bringing a flask of hot water, it's such a small thing when you look at the scale of what they were living with. No heating, no sanitation, I don't even think there was running water in the house. But just a flask of hot water to fill up a hot water bottle. It's that kind of little touch that builds the trust, that lets people take what for them is a risk to take a bigger step. So those would be my initial answers. I think I could go on with many, many cases, but I probably shouldn't. But thanks. It's a very useful question.
Great, thank you. The next question is from Pippa Johnson. So did you find any pattern of significant gaps in services and this contributing to interagency conflict? We find that safeguarding policies and guidance can direct people to support that isn't clearly commissioned or within service boundaries, so to all intents and purposes doesn't exist. For example, mental health support for people who experience hoarding.
Yeah, so this is our theme 4 and the management monitoring and commissioning bit. I think we did. One of the reasons we approached 5 different sites, and we did try to sample sites who had been quite actively working on issues of self-neglect, to try to learn from what they did, was we were seeing different configurations. I think your example of hoarding is a good one. There can be all kinds of gaps there. For one, if you look on the NHS site, it says if you score 4 or above on the clutter rating scale, you should see your GP. I've not yet talked to a GP who really knows what they're exactly meant to do about it if you do, but that's the NHS guidance. One way that was filled in one of the sites we looked at was, as I say, this kind of integrated team based around kind of Safer Homes initiative. And they brought together housing colleagues, a social worker. They had links with environmental health and others so that they kind of had that joined up system of working. In other areas, a lot has been done with peer support groups. And it's quite interesting how, in places that's been run by a psychologist or a trainee psychologist, um, elsewhere it's actually been done by housing officers with support from others. So there are different models that can be used. Um, but I mean, I do get, I think, what you're saying with mental health support. What you won't generally get is the specialist mental health support unless there are very significant and risk posing issues sitting alongside that hoarding. So I think it is a concern. There are different ways that the areas have tried to address that and set up support systems. But I think that, yeah, hoarding is estimated to affect 2 to 6% of the population um, in public health. So that's a lot of demand if we're going to meet it all.
Great, thank you. So there's a question here from Sarah Capstick, who says, with so much focus on crisis management due to budget constraints, how can hoarding and self-neglect be prioritised to free the required finances from agencies collectively?
Yes, this is the $100 million question, isn't it? Um, I think what we wanted to do, and this didn't fully work because we struggled to join up the kind of different agency records, was to try to track through a bit how sort of earlier upstream intervention could head off higher costs down the line for different agencies. We're fairly sure it does. It's just very difficult getting accurate cost estimates to prove it. But the costs don't fall evenly on agencies. So the agencies doing the input aren't necessarily the ones who make savings down the line. I think it really is something we do need to look at and monitor. Um, it it is, I think, a kind of flagging up to managers and commissioners again and again that um, if that intervention doesn't happen at an early enough stage, the costs increase significantly once it does reach crisis. How exactly that can be done, maybe some of it is looking at those creative integrated teams. It is that the communities of practice and perhaps more support for the practitioners who are involved further upstream before the crisis point, and they're desperately trying to refer in. Um, I think those are some of the key solutions, and maybe integrating the intervention a bit more. So the other gap that springs to mind in relation to hoarding is we're still seeing deep cleans being done without a full assessment as will this be maintained? So the deep clean happens, but the chances of the situation recurring are very high because no planning has been done about how that situation will be avoided in the future. So it's what we can try to do is that kind of integrated planning at an earlier stage. When that kind of thing happens, if we're doing a deep clean here, what can we put in place, even if that's befriending, if it's social prescribing, if it's something that's just been thought about before it moves on.
Great, thank you. We're almost out of time, so there's 2 questions left. So I'm just going to ask both of these, if that's okay, and ask you for 2 short answers, if that's possible. So the first one is, how do we support someone who has capacity but is living in unsafe conditions with a just leave me alone and just leave me be type response? Would inherent jurisdiction be appropriate here? So that's the first question. And the second question is, Is it particularly difficult to build relationships with people experiencing profound mental health challenges? And do you think that having NHS involved in these cases is helpful? So maybe
Okay,
we go
two
to the first
questions
one
that
first then.
lend themselves to short answers. Um, on inherent jurisdiction, I think that's quite a complex one, and we don't really have the case law to show how that would work in a self-neglect scenario. So my answer is going to be very cautious there. It's something that is worth considering, um, but I think it will be a challenge, given that inherent jurisdiction initially is about ensuring that a third party isn't constraining the person. Um, it is complex how that might apply in a situation that is genuinely self-neglect, where it's the person doing this to themselves. Um, that's nuanced by the fact that an awful lot of self-neglect can overlap with neglect by others. So it is complex, but it's something to think about. But I'm not sure it's going to be the get out of jail free card that it's sometimes talked about as being. And then the second question, Jeremy, was
It was
about.
about uh, where it's difficult to build relationships with people experiencing mental health problems. Is having the NHS involved in those cases helpful?
Potentially, yes, of course. I can think of people among our interviewees who said, actually having the peer support group and having the understanding from the people running that, in this case, housing officers, this is actually much better than bloody mental health. Um, it it depends. It depends. So yes, I think NHS mental health staff have the specialist skills and knowledge and the confidence to support with those cases. I think in an ideal situation, they can make that knowledge available, even if their waiting lists are so long that they can't directly see people, that they could maybe offer support and input for others that will be dealing directly with it. I would say not to underestimate the value of the relationship that other practitioners can have, an input they can have. But certainly, with profound self-neglect, mental health issues are clearly going to be a part of it often.
Sure. So thank you very much for coming. Please do take a moment to fill out the poll. And finally, thank you very much to David for coming in today and for speaking to us.
Thank you, everyone, for listening, and thanks, Jeremy, for the invitation.